Hi, thanks for joining me today. We're going to talk about an important issue in the developmental disability system, and that is the new vendor rate model that was established in California. I'm the parent of a 31-year-old son with autism, and this effort was a result of our fear of losing services and trying to understand how vendors are compensated and to make sure that our vendors were getting adequate payment for the services provided. This is going to be very mathematical. It's going to be a lot different than things you might see typically on a YouTube video or at a conference you might attend. So I apologize in advance for the volume of information. You can obviously pause this video at any time to explore the details because we're going to go pretty quickly. This was a 6-year effort by the California legislature to get this model done and approved, and we're going to cover that topic in about 40 minutes here. This is our agenda for the day. We're going to start with a real brief summary of the issue, talk about the DDS system and how funds flow to the consumer, then move on to the Burns study, which is the actual model that was created by Burns and Associates. Follow that up with 4 rate model examples in great detail, talk about some of the ongoing issues, and then briefly go over how you can help support the vendors, which in turn helps support your family member getting services. So California now reimburses its service vendors based on a rate model that was completed in March of 2022. It's important for the vendors and consumers and families to understand the mechanics of the model for a number of reasons. Nationwide and in California, there's a shortage of vendors. Low rates mean wages have to be low, maybe supervision is lower than needed, and it leads to a lower quality of services. It's difficulty hiring staff with inadequate wages, and that can lead to more overtime, financial losses for providers. And the future rates in California are going to be based on the formulas that were established in the model. This was a legislative effort, and the only way changes can be done are through the assumptions in the model. So we have to keep this up to date to keep rates adequate. So when you're talking to your service providers, working on your IPP, talking to the regional center or legislatures, keep in mind that the rate models are what keep the system afloat. So the way rates are set are governed by law, both federal and state law. Medicare actually provides for about half the funding for services for home and community-based services in California, and therefore California is subject to federal law. And the major one requires that the rates are consistent, but they also provide for a solid quality of care and that they're sufficient to enlist enough providers so care and services are actually available. The corollary to that is the rates also must approximate the reasonable cost that a provider incurs to provide services. So that there's 2 pieces. One, rates have to be set to entice providers to actually provide care, and secondly, approximate what it costs to provide the care. On a side note, in the red below, you'll see that in Pennsylvania, there's a lawsuit that's been ongoing now for about 4 to 5 years. It was brought by major service vendors in the state of Pennsylvania. And the premise is that the state of Pennsylvania has failed to live up to these 2 obligations. So the California developmental disability system as it stands today really dates back to 1977 with the passing of the Lanterman Developmental Disability Act. That was followed by about 40 years of rates which have been a little muddled, inconsistent. Sometimes they're frozen and not very transparent as to how they're actually established. But in 2016, the California legislature did authorize a new rate model to be completed that would address sustainability, simplicity, provide higher quality services and be transparent. So they hired Burns and Associates the following year to complete the rate model. They completed it in 2019, submitted it to the California legislature and to the public for comment, and the model was actually adopted in March of 2022. So this is a summary of how funds flow to the consumer in California. It all starts with the California General Fund, which is a shade over $300 billion. About a third of that money goes to the Department of Healthcare Services, and that's because that's the organization that takes care of Medicaid in California. The DDS has about a $14 billion budget, and that money flows to 21 regional centers that provide services to 350,000 people through the 6,000 vendors that are vendored in California. And money that's allocated to care for the consumers in California is governed by the individual program plan that are completed for each consumer. The IPP addresses concerns about their health and safety, where they're going to live, what their day activities look like, what kind of transportation they might have. It looks at how the situation is now, identifies any future needs they might have, how those needs are going to be met, and how we're going to measure whether the needs have been met. There are about 150 service codes right now in the system. Only 62 of those are covered by the new rate model, but those 62 account for over 90% of the home and community-based service funding. Each service has a service code attached to it. There's a few down below in the left-hand corner. Supported living services, for instance, is service code 896. Independent living is 520, and so forth. Both in California and the United States, there typically have been 5 different rate setting methodologies. There's a fee schedule, which is a amount of money for a certain amount of time, usually hourly or monthly. The negotiated rates between the service provider and the regional center, cost reconciliation, which reimburses vendors for their actual costs incurred. Tiered rates and bundled rates, which may bundle, for instance, transportation with a day program. California has opted to go with the fee schedule methodology for the future for the reason that it's simple. It's a fixed amount per month or per hour. It's pretty equitable in that there are regional cost adjustments in the model. It's flexible because it allows for the model to be adjusted with the assumptions. There are roughly 30 to 40 assumptions that go into each rate. So there are a number of considerations when they're adjusting rates going down the road here. And this is very transparent. You can look up the rates on the DDS website and know exactly how they're being calculated. The bulk of the residential day programs, employment, transportation, behavioral programs are covered by the model. And if you would like to see which service codes are actually covered, there's a link at the bottom of this page here. So an individual's IPP may list a variety of services. In this case, this is a consumer getting 24/7 one-on-one services. And there's 4 different services in their IPP: supported living night, supported employment, and maybe a day program. They might have different staffing ratios. These are the hours per month for each service, the rate per hour for each service, and the total funds per month that vendors are going to get reimbursed to provide services to the consumer. There might be some generic resources like IHSS substituted in for some of the services, though. Burns & Associates completed its rate model in March of 2019. Their task was to make sure they addressed issues related to sustainability, equity, transparency, and quality of services. They did that by looking at how vendors are paid, making sure rates were set at a level to ensure there was an adequate supply of vendors, which is required by Medicaid statutes. Looked at the type of services, tried to standardize the service codes a bit, and most importantly, established regional cost differences and adjustments based on the cost of services and throughout the state. They got their data from a variety of places. They looked at surveys from existing providers, family comments, independent data sources like the Bureau of Labor Statistics or the California Workers' Compensation Insurance Board. It's only 20% of the vendors in California actually participated, but those 20% represented over 50% of the services being purchased in California the prior year. And once their rates were established by the Burns model, it was determined they'd be phased in over a 26-month period. Immediately in April 2022, 25% of the difference between the proposed rate and the existing rate was added to the rates being paid vendors. July 2023, another 25% was added, bringing the total up to 50% of the difference. And in July of 2024, the full rate model will be implemented with the caveat that there's two separate payments. 90% of the rate will be paid as a guaranteed payment, and the top 10% will be based on a quality incentive program for which the actual metrics are still being established. And in July of 2026, anybody that had a rate above the rate model will lose their rate, and it's grandfathered until that time. This is a graphic showing the way the rates are being phased in. This assumes that the rate proposed by the model is $100 per hour, but vendors are currently only getting paid $70. So that's the far left-hand column showing 70 plus a $30 increase, which is due. The second column to the right of it shows 25% of the $30 being added to the rate to bring it to $77.50 per hour. Column to the right shows another 25% added to bring it to 85. And the far right-hand column shows the full implementation of the rate model, whereas we talked about 90% of the rate, or the $90 piece, the blue, is guaranteed, and the $10 top piece will be based on a quality incentive program to be determined. These are the standard components you're going to see in the rate model. Everything is constructed starting with wages, primarily for the direct care staff. So you start with wages. That's drawn pretty much from the Bureau of Labor Statistics for the Pacific region. It does allow an adjustment for overtime and for part-time employees. We add on standard benefits. We have a full slide on that. A productivity adjustment, which is an adjustment in the actual hours to allow for time that is not spent with the client. And the model increases the rate to account for that. There's a supervision line item, which is essentially assumes one supervisor for each 10 direct care staff. There's other costs related to mileage, reimbursement, meals, etc. And then the admin and program costs, which are standard plug-in numbers that we will also talk about. The rate model makes adjustments for the cost of living in each different region. They've gone through all 21 regional centers. They've assigned them region A, B, or C, and those are for wages, real estate, and travel. Far left-hand column here, a vendor working in region A, for instance, would receive only 95% of the statewide average for salaries. Region B would be right at the statewide average at 100%, and region C would be 115%. And the model makes similar adjustments for real estate and travel. Regions with less expensive real estate are region A, more expensive region C. It's the same with travel. The bottom box shows a comparison of the different regional centers. For instance, the Far North Regional Center, it's cheaper to hire people, so wages would be at region A. Real estate's cheaper, so that's regional A. But the distance required to travel between clients and to provide services is greater, so that would be a region C. Just the exact opposite is Golden Gate Regional Center, where it is expensive to hire staff. So they would be assigned region C. Real estate is also very expensive, region C, but the population density is much greater and the travel distances are a lot less, so that would be a region A. And all 21 regional centers have this type of assignment for these different factors. So we're going to get into doing some rate model examples here. As I mentioned earlier, there's 62 rate model service codes. When you take into consideration the various staffing levels for each of those codes, there's actually 476 rates per regional center. And remember, there's 21 regional centers. So the document that lays out these rates is thousands of pages long because of those sheer numbers and assumptions. The four examples we're going to look at are a supported living service model with one-on-one staffing, a site-based day program, a licensed community care facility at level 3, and what any rate would be paid to a behavioral consultant. So all the rate models start with an assumption about the wages being paid to staff. This is an example of the salary being paid to a direct care staff member providing supported living services. It draws on 3 different Bureau of Labor classification codes, as you can see here on the left. It assumes that this job is a combination of a home health care worker, a psych aide, and a recreation worker. Those 3 jobs have different regional wages based on the Bureau of Labor statistics. The rate model assigns a weighting to each one. It assumes that the job is 70% home health care, 15% psych aid, and 15% rec worker. If you take those percentages times the wages for each of those jobs, you come to a weighted average of $16.50 for this region. To the right, just for an example, independent living, it's a little different on the ratios. It assumes that the job is much more home health care, which makes sense because of the nature of the position. After you get the average raised rate, the rate model assigns regions to each one. So, somebody in a rural area, the rate model is going to assume that the adjusted wage is 95% of $16.50. Sort of suburban mid-cost areas, it's going to be 100%, so it's $16.50 there. And for high-cost areas, the rate model assumes that the wage rate's 115% of the statewide average, or just a shade under $19. The high-cost areas really are just Golden Gate Regional Center, East Bay Regional Center, and Sark. And now that we've established that the wage rate for this model is $16.50 per hour, we have to add benefits onto that. And the top left corner here is a summary of the actual benefits that the model assumes. We're not going to go into the actual percentages. The only one we'll talk about is health insurance. The model does assume that only full-time employees get health insurance. And this is a sort of a national average for the employers paying health insurance. The rate actually is $525 a month, but the model assumes that only 80% of the people take it. That's how we get to $420. It assumes 70% of the employees are full-time, 30% are part-time. This box shows what the percentages from above turn out to be. For a regular employee, the benefits are 23.5%. Adding on workers' comp, which comes from the statewide workers' compensation board, you get the bottom numbers. The rate again is $16.50 an hour. Benefits work out to $389 per hour, and workers' comp of $80. The wages for a direct care staff is $21.18. If they're working overtime, it's $27.84. The model assumes that 5% of the hours are overtime, and you get a blended average of $21.50. So that's the first box we're going to fill up above here, is the weighted average staff cost. We're eventually going to get to a target rate of $38.34 here. So an important concept in the rate models is that of the productivity adjustment. And this is an adjustment to the hours that a employee actually works with a client. There are extra hours that are being used for things that are not client related. In this case, paid time off, training, travel time, meetings, etc. And so the rate model allows for an adjustment to the rate to reflect the fact that the vendor cannot bill the regional center for these hours. So if, for example, paid time off, the model assumes that the full-time staff member is getting 200 hours per year, combination of sick leave and vacation pay. And they'll adjust the rate model accordingly. So if say, for instance, if 20% of your hours are being used for non-client related activities, the rate model allows to be increased by 20% to accommodate that. And we'll take a look at an example of that. So this is the math to show the productivity adjustment. In the upper left-hand corner here, these are the hours worked per week for a full-time and a part-time employee. The weighted average of those two means an employee works 36.35 hours per a week. The next 5 numbers are deductions from the total hours worked. It's for travel, record keeping, supervision, training, and paid time off. You have to trust me on the math a little bit on these, but of the 36.35 hours, almost 6 hours are used for non-client activities and therefore can't be billed to the regional center. So we deduct all those off. We come down to actual billable hours of 30.5 hours, and that means that roughly 19% of the hours are not billable. So the rate model allows you to take that 19%, multiply it times the weighted full and part-time staff cost per hour to come up with a productivity adjustment to add to the rate to allow the vendor to be compensated for those hours with an increased rate. So that productivity adjustment in this case is $4.09. We take that number, we're going to put it over here, second number in our column, and add it to our staff costs. And once again, we're getting closer to the target rate of 38.34. So this is an example of the comparison of the two different rates which the regional center could have allowed billing for. The top box shows the full hours the employee works. This includes all the hours that are not client related times their wage and benefit rate would be an amount of $782 per week. The second box is after we subtract off all the hours that we aren't allowed to bill for in the regional center methodology, multiply it times the increased wage and benefit rate that was adjusted upward 19%. You come up with also $782 per week. So you get the same amount of money. It's just a different way of arriving at it in the rate model. There's an adjustment to the model also to reimburse vendors for mileage driven with their cars. We're not going to spend a lot of time on this one. The statewide average that the model developer came up with per direct care staff per week was 100 miles driven. There's a regional adjustment factor here since this is in Region B, which is North Bay Regional Center. So that 105 miles driven per week, weighted by the full and part-time staff, multiply it times the typical federal reimbursement rate for mileage for employees. You come up with $52 per week divided by billable hours, and the billable cost per hour for mileage is $1.72. So we add that over here to the right-hand column also. One of the larger items in the rate model is the cost of supervision of the direct care staff. It assumes that a supervisor supervises 10 direct care staff workers. The wages per hour in this instance are about 50% higher than what the direct care staff is getting. We over here on the left we have the wages per hour, what the benefits are, the workers' comp, and we also assume that the supervisor is working 5% overtime. So the weighted cost for a supervisor for full and part-time is $32.08. We get down to the bottom, figure out the number of hours they're actually working, and essentially divide it by 10 people that they're supervising, and then by the billable hours per week to come up with a rate to add to the model of $4.41 for supervision costs. And again, that gets added over to our column, and you'll see at $4.41 is actually a relatively large number that's going to be charged for supervision. The model allows for staff meals being provided and paid for by the vendor. We actually don't see this very often, so we're not going to spend a whole lot of time on it. But let's just say that the staff meal per billable hour is 37 cents. We're going to add that on over here to the right. And the last two items in the rate model are the program costs and the administrative costs. The program cost, the survey came up with very wide range of values and estimates and a lot of outliers. So the rate model developer essentially assigned a value of cost per day for each direct care staff. And in this model, for supported living, direct care staff are assumed to cost $10 per day, $50 per week. And when you divide it by the billable hours, you come up with $1.64 for the actual addition to our rate model over here. Admin costs are everything else connected with running the organization. This is executive staff, bookkeeping, administration, costs for your office space, maybe utilities, anything that's not program related. And all the model rates assume that it's 12%, and that's 12% of the final rate. So it's 12% of 3834. 12% of 3834 is 460 per billable hour for admin, and we add that over on the right here. And you can see we have arrived at our target rate of $38.34 per hour that the vendor gets paid for supported living services in this with a staff ratio. This is a quick snapshot of what the model actually looks like if you pull up the the PDF files from the DDS. Essentially the 6 categories we went through, all these assumptions, but this is what the overall model actually looks like in the document. And just a quick review. These are the categories we talked about earlier. Note that the 4 items in the box here are essentially the direct care staff wages, the benefits, overtime, and the productivity adjustment. Those make up, in this case, 67% of the vendor's overall rate model. And prior California legislation, anytime rates have been increased in recent years, did require that any increases went to about 70% went to pay for wages. As you look at it, the other 2 big line items in the rate model are supervision and administration, both at 12% of the total rate. We talked about earlier, the different regions will have different rates based on wages, real estate, and travel costs. These are the differences for the different regions based on the wages. The 3834 we just came up with for the vendor rate would be lower in Region A, which might be Alta Regional Center or very far Northern California, where wages are lower. For Region C, Golden Gate Regional Center, or San Andreas or the East Bay, wages are higher, and the rate's going to be $42.50 for the vendor rate. If the staffing ratio is 1 staff for every 2 consumers or 1 staff for every 3 consumers, the rates drop accordingly. For 1-on-2, the rates drop to about half of the 1-on-1 rates, and 1-on-3 rates are about 1/3. This is a little different than how they calculated shared ratios before, and the shared ratios here are a little bit lower in the rate model than they had been in past years. So let's take a look at a second type of model. This is going to be a day program based at a site with 1 staff member for 4 consumers. The general categories are the same. Direct care staff hourly wages is slightly higher than supported living. We add on the same amount of benefits and a productivity adjustment, which is going to be a little different because there are additional hours for setup and cleanup of the site. So the productivity adjustment is a little bit higher. The direct care staff wage plus benefits and productivity adjustments is almost $27. The model assumes that there are 4 consumers, but they only attend the day program at an 88% rate. So you cannot bill the regional center for clients that don't show up that day. So the model assumes that only 3.52 consumers show up per day. So you take the care staff rate divided by the number of consumers to come up with a staff ratio rate of $7.66. Another difference in a day program model is there are facility costs. There's costs for the real estate. And the rate model developers assumed in this case that each consumer used 75 square feet, and the cost for that facility was $15 per square foot per year. That translated into about 85 cents per hour into the rate model. If you add on the same assumptions for supervision, program operations, and admin, you come up with the vendors the daily rate of $12.36, and that's for each of the 4 persons being served. And this is what the model would look like for a community care facility. level 3 with 4 residents. It's very different than supported living. The CCF model allocates hours to the house, and a certain number of hours per week depending on the level. It develops a house-wide cost and then divides by the number of residents, essentially. You can see they've got different line items here for line staff, lead staff, and administrator. These are the wages for those positions. The administrator obviously is getting a lot more in wages, and lead staff gets paid more. There's a consulting cost. Some of the same line items down here below, but it works out to essentially a total cost per resident per month of $7,802, and it's a little different. It's a monthly rate versus an hourly rate. And this is a licensed community versus supported living, which is unlicensed. So it's done a little bit differently than the prior rate models because of the licensing and the fact that the vendor actually owns the home. And this is a model for a behavior management consultant, and that's somebody that designs and puts in place behavior modification services for a consumer. It's more of a professional classification. So therefore, if you look at the staff wages are a lot higher, like $32, which is double supported living. The same rationale goes in for employee benefits and workers' comp. The productivity adjustment is a lot higher for this model, and that's because you have in this kind of job, you do a lot more traveling, a lot more time with record keeping and writing reports, training, supervising. So we're in the prior model. This number is $4 or $5 a hour. It's $27 per hour. The mileage actually is a lot more driving. It's 200 miles a week. There is really no supervision required in this job, so that's zero. And then program and admin are also, similar to prior models. But, for somebody getting behavior modification services, the vendor is going to get reimbursed $85 per hour, which is the bottom number here. So it's a different job entirely, which is why the rate is so much higher. So with those examples in mind, we're going to talk about 3 different ongoing issues. The first one is this quality incentive program, which is in the works. Second, talk about, now that we have rates, how do they get adjusted every year? And thirdly, a little bit about, how the rate model could differ than the vendor's actual use of the funds. So the quality incentive program, we're going to call it the QIP for short. Starting in July of 2024, the top 10% of vendor rates must be earned, and that's based on a criteria that's being established by the QIP task force, which is currently taking place now. This was not originally part of the Burns study. This is something the legislature thought up in their decision-making process to adopt this. It was decided that there must be some way to measure how well vendors were doing and how well consumers were being served, and there had to be some sort of quality measure. It'll be interesting to see what they come up with, because quality can be relative, and defining quality in a quantitative way is going to be an interesting process for them. They've done some of the vendor rates that are not commonly used. They've done some test runs on them, and things like have popped up, like what staff turnover ratio being lower than a certain number gets you money. Making sure your client gets to a doctor or a dentist once a year gets you more money, and how they establish the metrics and the targets are still in the works, but it's a mandate that this gets implemented starting in July of next year. I'm not sure how often it's going to get paid, whether it's every month or quarter or year. That's still in the works also. So this slide is a revision to one I did earlier. This is an important piece of the puzzle. The California Senate did pass a bill in July of 2023, which will allow increases to wages based on how much minimum wage has gone up in California in the prior years. The original model wages are based on Bureau of Labor Statistics wage rates from May of 2020. At that time, the rate model increased those by over 13% to reflect the midpoint of the first year of the model in January 2023. So starting in July of 2024, we should see a 7.12% increase in the wages in the model. And the little box down here to the right shows you how dramatic that impact is on the amount being paid vendors. A couple of possible improvements to the way they're doing this is maybe to consider making the increases based on wage inflation and not the minimum wage in California, which is capped at 3.5% per year. And also to consider making wages based on local minimum wages, because there are a number of places in California where the local minimum wage is much higher than the state. And this is an issue we probably could have mentioned earlier, but we'll get to it now. So the rate model is not meant to be an absolute guide on how vendors are supposed to allocate funds when they receive their reimbursement from the regional center. They do have some discretion over how reimbursements are spent. For an example, the column here on the left is the actual rate model that we looked at and the allocation of funds to establish the rate. But that's just the rate. How the vendors spend money might be, let's go to the right-hand column. A vendor may say, for instance, in the first column here that, rather than the $16.50 per hour wage rate in the model, we're going to increase that to 19, and we may increase overtime to 10%. Therefore, the staff cost goes up. On the opposite direction, they may say, well, the model assumes 200 hours per year for paid time off. We're going to reduce that to 100. They may look down here at supervision and say one supervisor for every 10 direct care staff is overkill, and let's change that to 1 out of every 15. We're not going to pay for staff meals. And if you total up all the differences, you come to the same dollar figure that the rate model is reimbursing you for. It's just you're spending it in a different manner. So the new model has had a fairly dramatic effect on things in the state of California. Vendor rates across the board are probably up 20 to 25% from March of 2022. Then probably will continue to go higher if they're adjusted accordingly each year. It's very transparent as to what's going on. You can, as we said, you can look up the models on the website. It's increased the equity across the different regions, which is one of the prior complaints, is that high cost regions were not getting adjustments for the cost of living, and vendors were getting paid the same as vendors in low cost areas, and some of that's been taken care of in the model. I'm not sure it's enough, but it's a good start. And this is simple. It's simple to understand. It's a good methodology for figuring out rates, and more importantly, to provide for mechanism to change going forward. So there's some simple ways to support your vendor and your family member going forward. And you have to keep in mind that even with these increases, the operating margins for vendors are still inadequate and mostly negative. The nonprofits can raise money to supplement that. For-profits are in the unfortunate position of having to figure a way to match revenues with the regional center reimbursements. So when you're doing your IPP, keep it in mind that every hour you negotiate and every service you negotiate helps your vendor receive more funding. If you are in touch with your legislators, let them know you're out here and you're keeping an eye on things. And the big piece is, as assumptions change over time, we have to keep an eye on it. A few examples, for instance, is this $16.50 an hour wage we've been showing on our model. That's out of date. There's nobody I know in supported living, at least in the northern part of California, that's under $20 an hour already. So that's inadequate. Hopefully that's adjusted more than just the minimum wage. The flip side, workers' comp has probably gone down by 30% since the time they did the model. Cost of gas has gone crazy, so the actual transportation costs have probably gone up. But it's important to make these adjustments as time goes on and let things sort of sit static. And to the extent you can, educate your friends and other people about how money flows to the consumers. It's easy to get very complacent about this if you're getting good services, but things change pretty quickly. and we have to stay on top of things as we're going forward. So thank you for listening today. I hope you enjoyed this and got something out of it, and it wasn't too much information too quickly. If you have any further questions or want further information, my email address and phone number are here. I love doing this and love helping families and uh, figure out how to get great services for their kids. There's also, if you need some light bedtime reading, there are the links here to the actual rate study and to Burns and Associates. And thank you, and keep involved.